I'm going to go ahead and get started to respect your guys' time. Good afternoon and welcome to today's webinar, Ask About PrEP. My name is Brandy Johns and I'm the Training and Development Coordinator for the Nevada Primary Care Association. This training is in partnership between Nevada Primary Care Association and Nevada AIDS Education and Training Center. I want to take a moment to thank them for helping us coordinate this session. Before we get started today, I would like to go over a few items so you know how to participate in today's event. We have taken a screenshot of an example of the attendee interface. You should see something that looks like this on your computer desktop in the upper right-hand corner. If you would like to listen in using your phone, just select telephone in the audio panel and the dial information will be displayed. Please be sure to enter your audio PIN followed by the pound sign. During the presentation, please make sure to mute your phone or your computer so we don't have feedback or background noise. Also, be sure to not put your phone on hold or we'll hear your hold music. You will have the opportunity to submit your questions to today's presenter by typing your questions into the chat panel. You may send in your questions at any time during the presentation. Questions will be collected and addressed during the Q&A session at the end of today's presentation. I would now like to introduce Mary Carls, Program Manager at Nevada AIDS Education and Training Center.
Thank you, Brandy. Thank you, everyone, for joining us today. I would like to also thank the Primary Care Association for hosting the webinar, and of course to Mr. Rob Phoenix for taking the time to present for us today on the very important topic of PrEP. So one final note, I would also like to remind everyone to please register for this webinar through the AETC link that Rob has on his slide, if you have not already done so. We are a federally funded program, and so in order to continue to provide quality continuing education programs around HIV and AIDS, we are required to evaluate all of our programs. I will be sending out an evaluation link at the end of the webinar, and completion of the evaluation is a requirement to receive the CME certificate, which I will be sending out within a couple of weeks of the program via email. So without further ado, I would like to introduce Mr. Rob Phoenix and welcome him. He is an APRN and the founder of the Huntridge Clinic in Las Vegas, where he practices family medicine, including prescribing PrEP and PEP. So Rob, thank you so much for being with us today, and I'll go ahead and turn over the program to you.
Again, go through your questions. Hopefully everybody can hear me. All right, so these are some of my disclosures. These are the objectives that we're going to cover, and these slides are going to be available for you after the presentation, so you'll be able to refer back to them if you need to. So what we're really going to talk about today is HIV prevention. So this is a great strategy to keep patients who are at risk of becoming infected with HIV free of HIV. It's a risk reduction strategy. It's a biomedical intervention designed to be used in coordination with things like condom use and partner notification, partner treatment, etc. So PrEP, basically, if you break the word down, means pre-exposure prophylaxis. We're protecting individuals before they're exposed to something, and in this case, we're protecting them against exposure to HIV. This slide represents the new diagnosis from 2010 to 2015. And if you look at the yellow section here where it says 80% of the diagnosed HIV infections in men were attributed to men who have sex with men contact. And of those, 24% were in ages 13 to 24, which continues to be the highest group for new infections of HIV. And 91% of the new infections in males were attributed to MSM, or sex between men and men. In 2015, 82% of those infections were also related to males and adolescents who were participating in MSM. This kind of gives you a graphic representation of unfortunately, the continual increase that we see in specific groups of populations across the United States. This is based on 2015 data from the CDC. You can see that 13 to 24, we still see an increase, and in the 25 to 34, we see the biggest increases. And these are among men who have sex with men. And that doesn't include any injection drug use or any other risk factors. This is just particularly looking at men who have sex with men. This slide kind of looks at that breakdown of men who have sex with men, injection drug users, men who have sex with men and injection drug users, and then the small percentage which is still attributed to heterosexual contact. Looking at this, it shows that the biggest population are young men of color. So you can see that 13 to 24, 54% of those new infections are in African American men who have sex with men, and 24% of those are in Hispanic men who have sex with men. If you look at those numbers together, that's 78% of all new infections. The communities of color don't represent 78% of our overall US population. So this is a big area that we need to target education, prevention strategies, energies, efforts to getting these guys engaged in care so we can slow this epidemic in the communities of color. This kind of breaks out a little differently, the percentages and the numbers of new infections in men who have sex with men in 2016. And again, you can see that over 10,000 of those new infections were in the African American community of men who have sex with men. So we need to really ramp up our strategies for getting men who have sex with men in the communities of color. We need to figure out ways to break down this barrier to get increases to access to care, figuring out what cultural barriers there are, and putting all those strategies in place so we can engage our communities of color. If you look at this map, you can see that Nevada still has a pretty fairly high number of new infections. We're 21.4, so we're higher than all of our surrounding states. We are rivaling with, Texas and Florida. There are parts of the South that have, super high rates. There are parts of Washington, D.C. where there's 55.6, and those numbers are equal or higher in some cases than some parts of Africa with new infections for HIV. So, we need to continue the work that we're doing with HIV, and PrEP, pre-exposure prophylaxis with Truvada, is a great way for us to do that. So PrEP is a strategy. It looks at condoms. It looks at treatment and diagnosis of STDs. It looks at getting patients engaged in care that are HIV positive. We know that if patients are engaged in care and they're on antiretroviral therapies, that if their viral load is undetectable, that based on the new strategy that's been announced from the CDC back in 2017 of U equals U, or undetectable equals untransmittable, we know that based on 3 very large studies looking at 50,000 different sexual acts between serodiscordant couples, where one partner was positive and one partner was negative, there were no linked infections in those serodiscordant couples, with the exception that there were a couple of patients who were infected before the partners became undetectable, and there were also a few infections in patients who were negative, but it wasn't linked back to the primary partner. Those infections were linked to secondary partners. So highly active antiretroviral therapy or treatment as prevention is a great way to keep patients from being infectious and a strategy for patients to prevent themselves from becoming infected. Looking at community engagement, how are we getting communities of color engaged, looking at surveillance data, knowing where the rates of new infections are coming from, like with gonorrhea and chlamydia and syphilis, knowing where those numbers are particularly high in your communities, because if those numbers are high, then you're likely to see co-infections with HIV, because those things very commonly go together, because those bacterial infections are also a risk factor for HIV infection. Partner services, making sure partners are linked up to care. If you've got positive patients in your practice, making sure that their partners are at least offered Truvada for PrEP. There's some discussion about if they're undetectable, do they need to really be on Truvada for PrEP? That's a discussion to have with your patients and their loved ones to see if that's something that they feel is a continued opportunity for them to continue to protect them. And then we look at prevention counseling, and we also look at some things around insurance. We'll talk a little bit about these as we go through the slides. So in our outreach, we look at identification of patients at risk. So knowing where your risk populations are living and frequenting. If you've got homeless quarters in your community, if you have gay and lesbian centers in your community, If you have, social clubs or sex clubs in your community, knowing where those are, bathhouses, so trying to target your outreach efforts to those. For the communities of color, sometimes that's through churches or through social support agencies, knowing what apps are available for your iPhone and for your Android phone. So Grindr and Tinder and Jack'd and Scruff and all those places where men are hooking up with men for sex. Knowing what support you have in your community, knowing who your resources are. So if you're in Southern Nevada, you've got the resources of the Southern Nevada Health District. You've got the Gay and Lesbian Center. If you're in Northern Nevada, you've got Northern Nevada Hopes. So knowing who your resources are and knowing how to tap into those resources and collaborating with them on getting patients engaged in care. Preventions, talking about PrEP, talking about counseling, getting patients engaged in testing, handing out condoms. This strategy does not replace condoms. It's an augmentation to condoms, because we know that prevention for HIV with Truvada, which is the only approved medication, only protects against new HIV infections. It does not protect against gonorrhea, chlamydia, or syphilis. And we are continuing to see very high numbers of those infections in our populations. We're starting to see, syphilis in our heterosexual couples, and we're also starting to see a resurgence or a recurrence of congenital syphilis in infants as well. Support, making sure patients are given the tools that they need to be successful. How do they adhere to their medicine? Making sure they have access to their medications. If they're going to the pharmacy, are there barriers at the pharmacy? Are there barriers with their insurances? Getting them engaged in support groups, having, maybe after-hour testing and treatment, or maybe after-hour PrEP clinic. Telemedicine's an option. And then treatment options, or test and treat. So making sure patients that are positive are engaged in care, their viral loads are undetectable, treating their opportunistic infections, and making sure that they're linked into care and that they've got the resources that they need for those support to be successful in treatment. These are the different biomedical interventions that we have for prevention of HIV and for prevention of STDs as well. So PrEP is a strategy which includes a medicine called Truvada. There's post-exposure prophylaxis, which is PEP or NPEP, meaning non-occupational exposure prophylaxis in those individuals who were exposed to HIV through transmission, typically through sexual contact. Anything traditionally outside of the hospital or outside of the healthcare environment kind of falls into this NPEP or non-occupational post-exposure prophylaxis, and it's treated the same way that we've done for years with needle sticks in hospitals. Treatment as prevention, making sure patients are engaged in care. Contraception, making sure we're preventing unwanted pregnancies. We haven't had any transmission of mom to child in a long time in Nevada. Let's keep it that way. So making sure that, new pregnancies are being tested for HIV, that they're being tested for syphilis, so we can prevent those cross infections. Making sure that we're diagnosing and treating syphilis, gonorrhea, and chlamydia. Making sure that you're offering patients 3-site testing, so you're doing extragenital testing. So you're swabbing mouths and pharynx, you're swabbing rectums in patients who are participating in rectal sex, and that is not just men who have sex with men, that can be women as well. And you can get gonorrhea and chlamydia in the pharynx, and you can get gonorrhea and chlamydia in the rectum, and you don't have any symptoms with that. And if you are only screening urethral samples, you're going to miss 75% of the chlamydia, and you're going to miss about 90% of the gonorrhea that we see out there, because those extragenital sites don't necessarily have any symptoms associated with them that patients are reporting. Voluntary male circumcision, there is some discussion about circumcision where there's uncircumcised men may be at higher risk based on the types of cells that are in the foreskin. Blood safety, we haven't had any transmitted cases of HIV in many, many years. And then injection safety, so engaging patients in harm reduction strategies. So if you have injection drug user patients that are participating in Truvada for PrEP, making sure they have access to clean needles and syringes through harm reduction strategies in your community. Knowing what those harm reduction strategies are. So Truvada is the medication that we typically use for HIV prevention. It is an NRTI, and this just kind of gives you a cartoon diagram of how the NRTIs actually work in prevention of HIV infection. Kind of the high-level overview is that it protects the virus from integrating into the cell and then being able to attach and replicate and become a viral-producing cell. So if we can block that replication, then we can also block the infection of HIV. We do this in HIV prevention with mother-child. We give them antiretrovirals during the pregnancy, during labor and delivery, and then we treat the child, the infant, postpartumly. We also do this through post-exposure prophylaxis, where when patients have a perceived or actual exposure to HIV, we will treat them with HIV-related medications to protect them from becoming HIV infected. So essentially, you're treating a patient for 30 days as if they have HIV infection, hoping that they got treated within the 72-hour recommended time frame, and that their exposure was relatively low, and then adding in HIV medicines, you're hopefully able to protect them from becoming infected. So this is the other big blue pill. Many of your patients may already be taking another blue pill, especially in our men who have sex with men population. They tend to use a lot of the blue pills, which is commonly referred to as Viagra. This medicine is called tenofovir and tricytidine, or Truvada is the brand name. It is once a day. It is designed to protect against HIV infection. It's also used to treat HIV infection, but it's always used in combination with other antiretrovirals for treatment. And then if you are doing post-exposure prophylaxis, Truvada plus one other antiretroviral may be an option for you when you're doing post-exposure prophylaxis. We'll look at the trials in just a couple seconds and look at the efficacy, but in the trial that got Truvada for HIV prevention approved, it was over 92% effective in reducing the risk of HIV infection in patients who take the medicines. This is just like metformin that doesn't control diabetes if it's in the medicine cabinet. This is just like the birth control that doesn't prevent pregnancy if it's laying in the bedside nightstand. So Truvada, when taken every day, can be 92% effective in preventing patients from HIV infection. So why do we need to even think about offering PrEP or Truvada for PrEP or medications for prevention of HIV? Well, we know for a long time that condoms work, but we still see new infections. So we need to come up with strategies in addition to condoms that can help patients protect themselves from becoming infected. We also know that vaccines are still many years away. Despite all the research and effort that's gone into them, we can't find a successful vaccination. This doesn't depend on sex. So, you know, if you take your pill every day and you forget that you don't have a condom and you meet Mr. Right or Mr. Right now, you can still have relatively reasonable safe sex as far as risk reduction for HIV. This enhances other methods of protection. So this works in conjunction with condoms. This works in conjunction with birth control to prevent unintended pregnancies. So men and women can take this. It's not approved, or the labeling indication is not stated for use in pregnancy. We don't have that data. And there's also not labeling data to support use in breastfeeding in moms taking Truvada for PrEP. But it does significantly reduce infections of HIV in both men and women. And, you know, like we talked about earlier for the treatment as prevention, this might be something that you want to continue with those patients who are undetectable, because things happen, life happens, and patients forget to take medicines, and sometimes we get other infections, and sometimes our viral load blips. And, you know, this will give you that extra strategy of protection in those patients where the viral load may not always be undetectable. So the PrEP study was done in 2010, which is one of the first studies looking at Truvada for prevention or HIV prevention. In 2011, the CDC came out with some interim guidance that said, hey, the strategy of pre-exposure prophylaxis for men who have sex with men looks like it's a really good thing. We should probably think and spend some more energy and time on doing that. In July of 2012, the FDA actually approved tenofovir and tricytidine for HIV prevention, or the brand name of Truvada for PrEP. In 2012, the CDC revised their guidelines, and now they are including heterosexual couples. And then we have a couple other revisions of guidelines over the next couple years. And then we also have some recommendations for PrEP for injection drug users. And then we also have guidelines from the United States Preventive Health Task Force, ACOG, International Society of AIDS, who also have recommendations about utilization of Truvada for PrEP for prevention of HIV infection. So the studies that I want to focus on are kind of the one in the red area. If you look at tenofovir in men, this was in all comers. This was from the PrEP study. This study was a placebo-controlled trial because at the time this study was done, there was no medication for HIV prevention. So in all patients who were randomized to this study, there was a 44% reduction in patients. And that includes patients who weren't taking Truvada. or those patients that were assigned to Truvada that weren't actually taking like they were supposed to. When you look at the patients who are actually taking their Truvada as they're supposed to, which is daily, there was a 92% reduction in those patients in risk of reduction of new infections. The Partners PrEP study, there was a 73% reduction in patients' acquisition of new HIV infections. So this is a really good indication that Truvada, when taken on a daily basis, can actually be very effective in HIV prevention. If you are looking at data in real world, if you look at the stuff from Kaiser Foundation or the Kaiser Healthcare System coming out of San Francisco, they have published data on over 5,000 patient lives covered by Truvada for PrEP, and to date they've not published any data about any infections with HIV in any of their patients, which is amazing that they have been so successful. And that's in all comers. That's men who have sex with men, trans women, trans men, injection drug users, heterosexual couples, serodiscordant couples. So they've got lots of data that we're able to learn from on how to use Truvada for PrEP and protecting our patients from HIV infection. So what is PrEP? It is pre-exposure prophylaxis. It's using a medication. In this particular case, it's Truvada, to protect patients from becoming infected who are at risk for HIV acquisition. How do you define risk? There are all kinds of different ways that you can define risk for patients. I consider any patient who has more than one partner as at risk for becoming infected with HIV. So I offer it to every patient who comes into my office that when we do their sexual health history, they say they have more than one partner. Because you never know who that other partner is going to be, or when their other partner might become infected, or maybe they're already infected. So protecting them so they don't infect their other partners is also important. The use of prophylaxis for HIV is as effective as use of contraceptive in pregnancy, and it's also compared to anti-malarial drugs when traveling to endemic areas of the country. So as a primary care provider, the things that you can also think about is this is a primary care benefit. This is a prevention strategy. So making sure patients who are eligible or inquiring about Truvada for PrEP, make sure their hepatitis vaccinations are up to date, making sure you're addressing their reproductive health care. There is the possibility that patients who are participating in certain types of sexual activities, particularly rimming, where they put the tongue on the rectum, can be infected with hepatitis A. It is typically a fecal-oral route of transmission, so there is no better route of fecal-oral than rimming. In patients with hepatitis B, it's transmitted the same way as hepatitis. Hepatitis C tends to be more common in injection drug use communities and in those with tattoos and in our baby boomer population. But there is some concern that we may be starting to see some increase in the amount of hepatitis C in men who have sex with men, because we're starting to figure out that there may be some blood exposure in rectal sex that may be putting patients at higher risk for HIV acquisition hepatitis C acquisition. It's cost effective. There's several studies out there looking at the pharmacoeconomics of this. And if you look at the pharmacoeconomics of prevention versus treatment, you save millions of dollars over the course of a patient's life if you protect them from becoming infected in the first place. Resistance is uncommon. As part of the screening process that you are doing for patients, you want to talk to them about what their risk for HIV infection is, assessing them for signs of acute viral syndrome, which we'll talk about in a couple slides, but making sure that your patients are not acutely affected with HIV, because again, Truvada is used for prevention. That's the only time it's used by itself. But if it's somebody who's acutely infected, then maybe we need to do treatment options for them as well. It has very few side effects. Typically, these are very transient. They are very short-lasting. My experience with Truvada for PrEP is my patients typically will complain of some nausea, some looser stools, maybe some diarrhea, maybe some mild body aches, maybe a low-grade temperature, and it generally lasts less than a week. Usually it's 2 to 3 days. I encourage all my patients to take their medicine at bedtime. That way they don't forget, but also they sleep through any side effects and they wake up and they feel absolutely fine. So this is a good strategy for them. Adherence is key to this. So if your patients are not able to take their medicines, obviously this is not going to work for them. And then I'll show you a couple slides in a minute that talk about the risk compensation, where we do not see lower rates of condom utilization. We do not see higher risk activities or increasing numbers of partners in the clinical trials. And my clinical experience shows that patients don't use condoms that are taking Truvada on a very consistent basis anyway. So this is a strategy that makes those behaviors a little safer. My strategy is to protect them from their behaviors, not to necessarily change their behaviors, but to make the behaviors that they're doing safer for them to engage in. Because people do whatever they do for the reasons that they do them, and making those behaviors safer is how we can help everyone with this. So we talked about condom substitution. I don't see this in clinical practice. In the clinical trials, this did not demonstrate that there was condom substitution. There's actually, in the clinical trials that were done to get Truvada for PrEP approved, there was actually increased utilization of condoms. There was actually no increase in risky behaviors. My clinical experience, most of my patients report a stable number of partners or actually a decrease in partners when I see them at their 3-month visits. This is every day. There is a study called Efficacy that is out there that looked at an alternative dosing strategy of taking PrEP, as they say, on demand, but that is not an approved indication in the United States. So daily dosing is the approved dosing for Truvada for HIV prevention in the United States. And then we need to look at screening for acute viral infections, and then we need to see these patients every 3 months, which is based on the labeling data, and screen them for gonorrhea, chlamydia, syphilis, HIV, at least annually screening them for hepatitis, and making sure that these patients' kidneys and liver function are still well. Truvada for PrEP is also excreted by the kidneys, so monitoring kidney function, creatinine function, GFR, provided the patient's GFR remains above 60, they're able to continue taking their Truvada. So the CDC guidelines for which patients is PrEP recommended: sexually active men who have sex with men, heterosexually sexual active men and women, and injection drug users. And you can see the different categories of things to look for in these patients. One of the common themes is recurrent bacterial infections. So if they've had gonorrhea or chlamydia or syphilis, these patients are at higher risk for getting infected with HIV, specifically if these have been rectal infections. So if they've had rectal gonorrhea or rectal chlamydia, there's a significantly higher rate of HIV infection in those patients. There's a lot of co-infection with syphilis and HIV. Nevada is still in the top 5 for syphilis in the country. So we see tons and tons of syphilis in Nevada, largely in southern Nevada. We make up about 75% of the Nevada population here, but we actually have about 90% of the new gonorrhea and syphilis cases in the state. So not something that we're very proud of, but it is a reality. Same thing for heterosexual men and women, looking at number of sexual partners, looking at commercial sex work, looking at high prevalence areas. So those sections of, like, for example, Washington, D.C., where we know there are higher rates of infection, in communities of color. Those types of areas are what they refer to in high prevalence areas. And then for injection drug users, anybody that's sharing needles or anybody that's injecting, potentially has the risk for transmission of HIV. So getting those patients engaged in harm reduction strategies like needle exchange programs, as well as Truvada for PrEP, are recommendations for this population. One of the things you need to do before starting patients on Truvada for PrEP is make sure they have a negative HIV test. So generally, that's within 2 weeks of starting their Truvada. I usually have patients come into the office. I see them in the office. Depending on their risk, we may do a rapid HIV test for them in the office today, or we'll draw blood for them. Generally speaking, with the time that it takes for the pharmacy to get the medicine, for the prior authorization to go through, for the patient to figure out that they're going to have a copay and come up with that money or get their patient assistance cards, etc., that's enough time for me to get my results back and know the patient has a negative HIV test and they can go ahead and start their Truvada. Making sure they have no signs of acute viral infection, which at this time of the year kind of is bad because it's flu-like symptoms. So symptoms of acute viral infection are fever, chills, night sweats, weight loss, body aches, night sweats. Those are all symptoms of acute viral infection. Swollen lymph nodes are very common. So making sure that your patients are not acutely infected with HIV. I ask all my brand new patients if they've had any sex in the past 72 hours or the past 3 days. And depending on their answers, I will screen them for post-exposure prophylaxis, because if they've had a high-risk sexual encounter in the past 3 days, they might be a better candidate for post-exposure to prevent them from becoming infected based on an exposure to HIV. And then at 30 days, when their follow-up comes around, talking about PrEP with them at that point to keep them continued protection going forward. Making sure their renal function is normal, if they're diabetic, if they have high blood pressure, there's no contraindications based on those diseases, but you need to look at the kidney function, because we know that diabetes and hypertension can affect kidney function in patients. So as long as their GFR is greater than 60, it is not indicated with a GFR below 60. We want to make sure that we're documenting HPV status, making sure patients are not acutely infected with hepatitis B. One of the components, the tenofovir of Truvada, can be used for treatment of hepatitis B. So there's not a contraindication to using Truvada for PrEP in those patients. You just have to be very careful when you withdraw the Truvada, because if they have hepatitis B, you can actually cause a flare of their hepatitis B, and that can make them very sick. So these are the recommendations from the CDC for follow-up on patients. All patients need to have an HIV test. They all need to be counseled about medication adherence, making sure they're taking the pill every day, identifying barriers to taking pills on every day, maybe providing pill boxes, coming up with strategies of how they can take the pill, reminders, behavioral risk reduction, so engaging them in harm reduction strategies, talking about condoms, talking about their sexual health history, looking at how many partners they have, where are they finding these partners, how are they screening their partners. A lot of my patients will tell me that, oh, my partner told me they were clean. What does that mean? They're clean. They took a shower before you guys hooked up. I'm not quite sure exactly what that means. But in context, it's usually they don't have gonorrhea, chlamydia, or syphilis or HIV. But when was that testing done? If that testing was done, 9 years ago, that's not very reliable. But if it was done, 9 or 10 days ago, then that's probably a much more reliable test. Looking at patients for STD, you will find a lot of co-infection with gonorrhea, chlamydia, and syphilis. Offering patients 3-site testing. For 3-site testing in our office, we do pharyngeal swabs that we perform, and then we send the patients to the bathroom to do their own rectal swabs. And we use the same NAT testing that we do for cervical or urethral swabs. And those are very highly accurate in patients. It's very common to find co-infections with gonorrhea and chlamydia when you do the first pharyngeal or the first rectal test that a patient's probably ever had. So telling patients that, this is potentially going to come back positive, it's not a surprise when they get that phone call from you, and then they have to get scheduled for treatment or follow up with the health department or wherever they're going to get their treatment. Every 3 months, you're going to continue to assess renal function. You're going to look for women who are of childbearing potential. You're going to make sure they're not pregnant. At least once a year, you want to be testing for hepatitis B. And then you need to continue to evaluate their necessity for Truvada for PrEP. People's risks change. A lot of men who have sex with men are looking for Mr. Right now, with the ultimate goal of finding Mr. Right. And sometimes that happens sooner than others, and sometimes that doesn't happen at all. So every time they come in, finding out if they continue to need Truvada. This is a short-term strategy. This is not a long-term solution to a problem. This is designed to be a short-term strategy to risk reduction for patients. So, PrEP candidates are men who have sex with men, who have a positive partner, who've had recent infections with gonorrhea, chlamydia, or syphilis. They have high numbers of sexual partners. Knowing how to ask questions about partners. When I screen patients, I don't use words like heterosexual, homosexual, gay, lesbian. I use nondescript terms like men who have sex with men. I ask questions kind of generically. Are your sexual partners men, women, or both? When you have sex with men, do you top, or do you put penis in a rectum, or do you bottom? Do you take penis in your rectum? Do you do oral, rectal, vaginal sex, knowing where patients are using body parts and what body parts are using? And then talking about when do they use condoms, how do they negotiate condoms, when do they decide to use a condom or not, and why do they make, how do they make those choices that they're making? Also looking at patients who are engaging in commercial sex, whether that's in the brothel or outside of the brothel. Those people who are trading sex for life support, So patients who are engaging in sexual behaviors for food or security or housing or clothing or some kind of tangential need, those are patients who are at very high risk because they will oftentimes compensate their risk strategies to make up for their needs. So if I can do sex randomly for $50 with a condom and $100 without a condom, and I need to pay my rent or I need to pay my phone bill, I'm more inclined to do the $100 sex. So offering Truvada for these patients will help protect them from becoming infected. We talked about many of these things. We talked about who their sexual partners are, what parts of their body are used, if they've had any sexual partners, if they've used any substances, methamphetamine, cocaine, alcohol, because these do change perceptions and they do alter our risk strategies. So that will put us at risk sometimes for things that we might not necessarily be at risk if we weren't under the influence of any kind of a substance. For trans individuals, we know that trans individuals, just purely based on the fact that they are transgender, have very high rates of HIV infection. If you add into the fact that they are trans women and then add on top of that they are trans women of color, their risk for HIV infection is astronomically high. In heterosexual couples, looking at their recent STD patterns, have they been infected with gonorrhea, chlamydia, or syphilis? Do they have high numbers of sexual partners? You know, where are they living? Where are they working? Are they participating in commercial sex? We have a lot of, massage parlors in town. We have a lot of out-call services, girls to your room kind of thing. We're a highly sexual population. So knowing where patients are making their money or how they're making their money sometimes can be very important in helping them identify their risk. And all dancers in the strip clubs don't just dance. Things happen outside of the strip clubs as well. Injection drug users, making sure that they are offered PrEP as well, because if they are using and having sex, their strategies are much different than if they're not under the influence. So they will do things potentially that they wouldn't necessarily do, so that increases their risk. So making sure that they are injecting safely with harm reduction strategies, as well as offering them Truvada for PrEP. I think we've already talked about this. It's inconsistent condom use or people who are engaging in higher risk behaviors. When you start providing PrEP in your office, you want to assess every visit, adherence, risk reduction, you want to do some counseling, and you want to make sure that you have condoms and lube. Condoms and lube are readily available in my office. I have them in every patient exam room. I have them at my check-in desk. I have them at my check-out desk, and patients are free to take however much they'll use. There are opportunities to partner with your local health department maybe to get condoms and lube for your office. There's a company called One Condom that makes 60 different sizes of condoms. So patients can actually log on to their website and actually order custom sized condoms, because one of the common complaints that I hear is it's not big enough, or too tight, or it fell off, or it wasn't the right flavor or the right texture, it didn't have the frilly parts. So One Condom makes 60 different condoms, so they basically cover everything from the size of an acorn to a watermelon. So patients don't have any reasons to not use condoms. It takes out one of their excuses. Looking at partners, knowing their social history, if they're homeless, if they're couch surfing, making sure that they are, getting access to resources as well. You should only prescribe 3 months of Truvada at one time. I've had patients come in and say, I went to see my provider the other day and he gave me a year of Truvada. I didn't feel comfortable with that. I'm like, I'm really glad that you're here, because that's not a good idea. Because if you're not coming in every 3 months to be retested, we don't know that you haven't been infected, and we don't know that this is right for you to continue. So we need to make sure that patients are protecting themselves and they're testing every 3 months. Insurance approval. There are some insurance plans who make this very difficult for patients with prior authorizations, recurrent prior authorizations. United Healthcare for about 4 weeks had a strategy where they thought making patients reauthorize every 3 months was going to be a good idea. And then they figured out that that was not such a great idea based on feedback that they got from the community. So they have taken away some of their prior authorization requirements, but they've replaced them with higher copays. So they've moved Truvada to a tier 4 on many of their plans, making it much more expensive for patients. So getting patients set up with pharmacies that know how to get patient assistance programs or medication assistance programs. There's a really good program through Gilead, which makes Truvada, to help patients get on medication for as inexpensively as possible. For ongoing care, you want to make sure that you're documenting their continued negative test, they continued normal kidney function, there's no contraindications to the medication, that there are documented hepatitis vaccinations, and that they don't have hepatitis B. This is kind of a reflex back to some of the efficacy data. The placebo is the gray, the orange is the tenofovir gemcitabine. You can see that there is a positive trend towards protection in patients. This was a study that compared tenofovir to TDF, which is tenofovir Truvada in its commercial form, to placebo, and there was protection in those patients who were taking Truvada. This was the risk reduction in patients who were involved in, I forget which study this is, but there was a 71% reduction in women and a 63% reduction in men. This shows some of the trials that were used in men who have sex with men and women and injection drug users. And it looks at the number of infections in patients. So in PrEP study, there were 36 infections in the Truvada group, and there were 64. But when you do a deeper dive into those, there were some of those patients who probably were positive at entry into the trial and probably should have been screened out. But because of the technology that was available at the time, we only had the antibody testing. Those patients were missed and were included into the trial. Adherence is very, very important. You can see that in the Partners PrEP study that in patients who take Truvada, the risk reduction is 90%, significantly higher than the 75% in patients who were taking any type of drug or had no measurable level of Truvada in their systems. Very well tolerated. Side effects are very mild. Typically, they are very short-limited. Encouraging patients to take this at bedtime is very helpful for patient compliance and adherence. It also helps to really minimize the amount of side effects that patients are experiencing. This shows us that there was a trend towards a decrease in the risk behavior. This has always been a topic of conversation about Truvada for PrEP, making sure that patients are reducing risk. So you can see that over the course of time, there was a trend towards reduction in risk-taking behaviors of patients. Partner numbers also decreased in studies with patients in Truvada for PrEP. Condom use increased, which we've talked about. So this is a great opportunity to talk about patients, about their sexual health. It's great to incorporate a sexual health history into your HPI, asking patients about their risk for sexually transmitted infections, asking them questions about who their sexual partners are. Patients go through risks or seasons of risk where they may have more partners during certain times of the year around events like cruises, vacations. So maybe that's a strategy for this patient, is to be on Truvada for their vacation. When they come home, they settle down their behaviors and they can go off of Truvada for PrEP. Talking about how to prevent yourself from getting infected with gonorrhea, chlamydia, and syphilis. Looking at prophylaxis, frequent STD testing. That's another population that's a great candidate for Truvada for PrEP, is if you have patients who are coming in routinely asking for testing for gonorrhea and chlamydia and syphilis, this might be somebody that would be a really good candidate for Truvada for PrEP. A lot of people don't know they have HIV. They don't know about PrEP. They don't know how to access it. They need to have resources available to them. So there are resources available to you as clinicians to help patients with their adherence and access to knowledge about Truvada. Many patients will find this information on the internet and they present your practice saying, hey, I read about this strategy called PrEP and I want to be on that. So knowing what PrEP is and how to engage your patients in conversations around their risk reduction strategies and assessing them for Truvada for PrEP. Or if you're not comfortable providing Truvada for PrEP services, knowing the resources in your community that you can send patients to. Planned Parenthood is a great resource because in most of the locations, Planned Parenthood offers Truvada for PrEP for patients who present, and they do see men as well as women. So that's a great strategy for areas where you have access to Planned Parenthood. Or knowing where your patients live. There's a website called preplocator.org that patients can put in their zip code, and it will pull up a list of providers who offer Truvada in their communities. And that is a program that's done through Emory University. And as part of the process of getting listed on that website, Emory validates practices by calling them and asking questions of the front desk staff or whoever's answering the telephone. Hey, do you know what PrEP is? Do you offer PrEP? Making sure that the staff at the office is aware of Truvada for PrEP, so that when patients are calling, they're getting the right information and getting scheduled for appointments. So this goes beyond just the providers. So there is training and education that needs to happen with your staff, because this is still a relatively new concept. So patients will present often asking for this, and staff will be like, yeah, I don't know what that is. Or they may get, like, we don't do that here, because the staff are unaware of this. These last couple slides are just some educational materials that are available about Truvada for PrEP, about making choices from Project Inform. These are some posters and brochures from the New York Department of Public Health. PrEP in the future, they're looking at rectal and vaginal types of suppositories or applications. They're looking at other oral formulations. They're looking at longer acting injectables. There's a study with cabotegravir, which is looking at an injectable form of Truvada, HIV prevention, where they're right now about 2 months for an injection. So every 2 months, a patient would theoretically come into your office for an injection. Making sure that you have coordinated efforts to educate your staff as well as patients. Visible marketing campaigns, making sure that you are educating providers as well. Working with your local testing resources and offering Truvada or prevention through them. Promoting HIV testing in adherence with the CDC's opt-out guidelines, but making sure that patients are offered HIV testing. It should be standard of care in your practice, especially for those patients who are coming in for the first time, just like you do for hepatitis C, just like you test for, screen them for diabetes and cholesterol. You should also be screening them for HIV. And if you just make this part of your normal conversation, or the little spill that you give patients about, hey, we're going to test for these things, and we test all of our patients for HIV, because we do find patients occasionally who are HIV infected that don't know about it. And it's based on recommendations from the United States Preventive Task Force that everybody between the ages of 13 and 64 should be tested at least one time in their life, or more frequently depending on their risk. So we do that as part of our standard of care. So just incorporating that into your speech. If you do have a patient that becomes pregnant while taking Truvada for PrEP, there is an antiretroviral pregnancy registry that patients are encouraged to enroll in, and they will follow the pregnancy to make sure that everything comes out okay. And they will also follow the delivery and follow the child afterwards to make sure there are no medication-related issues. PrEP works, but you got to offer it, and patients have to take it. It's most efficacious when we coordinate with the community. So working with your testing centers, making sure that patients have access to PrEP, making sure patients have access to testing, making sure that they have access to education about reliable methods of prevention, making sure the information that patients are getting is reliable from valid sources. Thebody.org is a great source for HIV information as well as prevention. Following treatment guidelines, testing patients frequently, making sure you're testing for STDs as well. And then raising awareness in your community and erasing some of the stigma that goes along with HIV as well as prevention. And that's pretty much my story, and I'm sticking to it. And these last couple slides are really just some resources that, again, these slides will be available to you after the presentation is over. And I think we'll take some questions now.
The phone lines are now open if anyone has a question.
So where will I find the question?
When you did a print.
Does anyone have any questions?
Oh, is the worksheet that was good, not the guidance one. The guidance one is still.
Well, thank you everybody for joining us today. I think Mary had a few extra comments on the CEUs.
You do have the
Just,
Mary, are you there?
Yeah, I'm here. I think I was muted there, but I'm here. Just a final reminder, I'm sending evaluations out now, and then you just need to complete the evaluation, and CME certificates will go out in about a week or two. That's kind of all I had to add, really. Thank you, Rob, very much for a great informational presentation.
Yes, thank you, Rob, and thank you, everybody, for joining us today.
Thank you. Have a great day, everybody.